Welcome, everybody. It's Friday, yes, May 24th and 2024. And we're super excited to once again have Tanner Smida on the webinar. As I mentioned last week, Tanner is going to be assisting me in the future with the Florida EMS webinar. Um, Sometimes when you meet people out in the world and you know that they're winners, you want to bring them into the fold, and Tanner is just that guy. He's done amazing work. And today, this will be a first for the webinar. He's not just presenting one paper, he's presenting two of them. So without any further ado, Tanner, thank you so much for joining us again, and take it away, my friend.
Thank you very much for the kind introduction. So yeah, I'm Tanner Smida, student in the MD PhD program at West Virginia University. And I'm going to be presenting, as Dr. Antevi said, two papers today. So the first is going to be on the sizing of the iGel supraglottic airway device. And then the second is going to be a comparison of post-resuscitation epinephrine and norepinephrine in the pre-hospital setting. So just getting us started here. So the first paper, this is a brief report. It was published in Air Medical Journal in April. So out there in the literature, there are basically two methods that have been presented to size iGel supraglottic airway devices. The first one is based on ideal body weight. This is the kind of manufacturer recommended method that we're all familiar with. And there's also a publication out there evaluating a sex-based method for, again, this is for adult patients. And the sex-based method says basically all females get a 4, all males get a 5, right? And so for this sex-based method, there's actually prospective randomized evidence. 3 French hospitals, 2 18-month periods, anesthesiologists for cases that these were healthy patients coming in for elective anesthesia cases. They, in these 18-month blocks, they placed iGels according to either the weight-based or the sex-based system. And so what they found was that when they placed iGels according to the weight-based system that we're all familiar with, I'm sorry, I'm gonna turn that radio down.
Go ahead, Tanner, no worries.
Sorry about that. So anyway, this prospective study showed that if you use the weight-based system that we're all familiar with, about 7% of patients either had to have an iGel switched to a different size, or they had to receive endotracheal intubation. Whereas whenever they used the sex-based system, only about 3% of these patients had to undergo either swapping the device or endotracheal intubation. Now, interestingly, because this was an anesthesiology study, they had ventilators, right? They were able to measure leak pressures. They also found that patients that were treated according to a weight-based system had lower leak pressures than patients treated with the kind of sex-based size guide. And this is important to us in the pre-hospital setting, right? We treat a lot of patients with respiratory disease. A lot of iGels are placed during CPR in the pre-hospital setting, right? And in the post-ROSC setting, we know we have atelectasis. And we may need to deliver higher peak pressures to these patients. And so it's possible that if we use the sex-based method and the airways are kind of seating better in the airway, we'll be able to deliver these higher peak pressures and get better outcomes potentially. But the question is, this study was done in the hospital with healthy, fasted patients undergoing elective anesthesia. And so the question is this generalizable to the pre-hospital setting? And so that's the question we asked using the ESO annual data sets. And so basically what we did is we looked at all patients who had an iGel placement attempt between 2018 and 2021. And for those cases, we took the first iGel insertion attempt. We looked at the timestamps. We took the first insertion attempt, and that was kind of the unit of analysis for this study. We excluded all airways placed in pediatric patients, and we excluded all the airways that didn't have age, sex, weight, or placement success documented in association with that airway attempt. Overall, about 6.5% of the initial insertions were unsuccessful, right? This is across the board. This is trauma, medical, cardiac arrest. So the first thing we did is kind of stratify success by device. So we can see that the size 5.0 device had the highest success, only about 5% of them were unsuccessful. And patients who received a 3.0 had the highest, or had the lowest success, about 8% of them were unsuccessful. For our primary analysis, what we basically did is we looked at all iGels that were placed in accordance with the weight-based method. We looked at the insertion success, and then we also looked at all of the iGels that were placed in accordance with the sex-based sizing method, and we looked at their success. And so what we found was rates of failure were very similar between the two groups. So about 6.4% when we're using the weight-based method, and about 6% when we use the sex-based sizing method. We also performed a sensitivity analysis excluding patients that received that 3.0 size iGel, and the results were similar. So 6.1% failure with the weight-based versus 6% with the sex-based. Logistic regression and review relationship. So in conclusion, again, from this brief report, there's all the limitations that come along with all retrospective observational data apply here, right? We're relying on EMS provider documentation of insertion success. We don't really have objective measurements like end tidal CO2. But in the context of prior literature, this brief report suggests that a sex-based method of size selection may be equivalent to the weight-based method when we're looking at the probability of unsuccessful iGel placement on the first attempt, right? And this might be just another method to kind of decrease cognitive burden during those first few critical minutes of a cardiac arrest, for instance, with equivalent results. And again, looking at the randomized data, maybe even higher leak pressures. So that's our first brief report. So now moving on to the main paper that I'll be presenting today. This is a multi-agency target trial emulation study comparing post-resuscitation norepinephrine to epinephrine in the pre-hospital setting. This was published in Resuscitation a few months ago. And so, we know from prior studies that our groups presented on this webinar that hypotension is very common following out of hospital cardiac arrest, right? As many as 40% of patients will develop hypotension following return of spontaneous circulation prior to hospital arrival. We know this is associated with dismal outcomes. And, vasopressors are an important tool in our toolkit to manage hypotension and restore perfusion in these patients and potentially prevent end organ damage and prevent rearrest, right? Now, some recent studies have suggested that basically post-arrest using norepinephrine infusions result in much better outcomes, right? They basically suggest that post-ROSC epinephrine infusions is like poison to post-arrest patients. A few of these studies have been done in the hospital, so we're looking at vasopressors that are used in the emergency department and the ICU, and they've suggested that if you use epinephrine, you see more mortality, more refractory hypotension, more rearrest, more death, right? And then recently, again, within the last year, the first pre-hospital study was published out of Seattle. And when they compared patients who were treated with norepi versus epi at their agency, they found that epinephrine was associated with a greater than threefold increase in the odds of rearrest, right? And again, recently we presented a paper on rearrest. We know that's associated with bad outcomes. And so using this estimate of effect size from this pre-hospital study, it suggests that a number needed a harm of 4, right? So basically, for every 4 patients that we treat with epinephrine instead of norepinephrine, we're basically causing 1 rearrest, which if that's true, that's really unacceptable, right? And this is also a question of interest to West Virginia, where our group practices, because ground ALS units in the state do not carry epinephrine, right? Our aeromedical services carry them, our CCT medics carry them, but the ground ALS units that provide care to the majority of out-of-hospital cardiac arrest patients in the state, they basically only have epinephrine infusions, right? And so before we kind of made the leap and said, okay, we're going to add this to our formulary and our protocol and make everybody purchase this medication, which, epinephrine is definitely less expensive. We wanted to do our own study, use the ESO data set, try to get a large sample size, geographic generalizability, and kind of repeat these analyses for ourselves. So again, you'll notice in the title of this paper, we refer to this as a target trial emulation. So basically what a target trial emulation is, it's basically a set of methods that it's a framework that's been published. And it's basically, if you follow these methods, it helps you avoid common pitfalls that are common to all observational studies, right? Avoid common sources of bias when we're working with retrospective observational data, right? So again, these have been published in the paper. We've cited all kind of the source literature, but there's a few steps whenever you're taking this approach. The first one is you basically have to write down what you think the ideal randomized controlled trial would look like to answer this question and your inclusion and your exclusion criteria, and basically write out what you would like to see, right? And then you try to emulate that as closely as possible with the observational data that you have. So one important wrinkle to this is when you're coming up with your inclusion and exclusion criteria, you have to make sure that that information is available at the hypothetical time of randomization, right? So the information would have to be available at the time these medications are being administered. one thing that a lot of the previous studies did is they excluded all patients who had both epinephrine and norepinephrine administered in the pre-hospital setting or in the ED or the ICU. We didn't do that because, for example, when you administer epinephrine, you don't know if the patient is going to have severe refractory hypotension that's going to require a second line pressor, right? And it's also conceivable that the first agent you choose might impact the probability of you requiring a second pressor, right? If one pressor is less effective. And so again, yeah, all of our inclusion and exclusion criteria were available kind of at the time of randomization. We included only 911 responses, patients 18 to 80 years of age. We excluded everybody who was a resident in a nursing home or assisted living facility at their time of arrest, trying to get rid of all the patients that had a poor functional status at baseline. Anybody with a DNR, pulse, those patients were excluded. We excluded patients who had a vasopressor or inotrope infusion prior to the first return of spontaneous circulation. We did that to exclude patients who, they might have been treated by agencies who have epinephrine infusions intra-arrest as part of their protocols. And then we also excluded patients who had rearrest prior to vasopressor administration, right? So in this data set, we saw a lot of patients who had, maybe one rearrest, they were resuscitated, another rearrest were resuscitated, and then paramedics on scene finally hung a vasopressor infusion to stabilize the patients, right? And of course, in this case, rearrest was our primary outcome, and rearrest can't be caused by a drug that has not yet been administered, right? So to be logically consistent, that was one of our inclusion and exclusion criteria. Another kind of important wrinkle to this is it requires you to define time zero in your follow-up interval. This is very important, especially for pre-hospital studies, because, so for instance, consider, all rural agencies use one vasopressor and all urban agencies use another vasopressor, right? Now, the urban agencies are going to be exposed to post-arrest patients for much shorter periods of time, right? Their transport times might be 4 or 5 minutes to the nearest facility, whereas the rural agencies might be sitting with these patients for 45 minutes. And so when we're looking at a phenomenon like rearrest, right, something that's observed in the pre-hospital setting, rural agencies are going to have a much higher chance of actually observing a rearrest than an urban agency that's just 3 or 4 minutes away from the emergency department. And so defining that follow-up interval is very important to ensure comparability between these two groups. In terms of analysis, so of course we can't actually prospectively randomize these patients to a treatment. This is a retrospective study, and so we used multiple different statistical techniques to adjust for baseline imbalances and confounding variables. In this study, we used logistic regression, multivariable regression, and propensity score matching. Again, this was an ESO study, so we started out with just over 400,000 out-of-hospital cardiac arrest patients. And after excluding all the patients that didn't meet our inclusion criteria, we ended up with a final sample of just under 2,000 patients who received either epinephrine or norepinephrine. It was a pretty even split, about 53% received epinephrine, the rest received norepinephrine. So moving into the baseline characteristics now. So just based on our inclusion and exclusion criteria and how we kind of funneled patients into this study, we were fortunate that these patients looked very similar, right? A couple differences that I do want to mention. So patients that received norepinephrine, it took a little bit longer for them to get a vasopressor following return of spontaneous circulation. So patients that received epinephrine got it in about 7 minutes. Patients that got norepinephrine, it took them about 11 minutes to have that first, the vasopressor infusion initiated. In addition, patients who received norepinephrine received a little bit more fluid, about 200 more milliliters of fluid prior to vasopressor administration. And they also had a lowest systolic blood pressure. So the median lowest systolic blood pressure in the norepi group was 70 versus 78 in the epinephrine group. When we look at our kind of categorical Utstein predictors of outcome, our groups were very well balanced, no statistically significant differences when we're looking at sex, etiology, witness status, location, bystander CPR, etc. One thing we thought is, maybe all the patients who receive norepinephrine are being treated by critical care units, right? HEMS or physician response units, right, out in the field. But it seemed like an equal number of patients or an equal proportion of patients between the two groups were treated by critical care level providers. In terms of our outcomes, the only statistically significant difference was observed with respect to shockable rearrest. So patients who received a post-ROSC epinephrine infusion were about twice as likely to experience a shockable rearrest. A rearrest is a result of a ventricular arrhythmia in comparison to norepinephrine. So about 6% versus about 6.3% versus 3.7%. And that was significant. Again, this is just unadjusted differences between groups. Uh, so for our multivariable modeling, again, we use both logistic regression and also propensity score matching. And we used two different models. So our first model included all of our Utstein characteristics, as well as a couple of variables that were unique to this study. So we looked at the follow-up interval, as well as the ROSC to vasopressor interval. The follow-up interval, I've already described why we included that. We included the ROSC to vasopressor interval to account for differences between the two groups in speed of hypotension development, as well as possible differences in provider familiarity with administering each agent as a vasopressor infusion. And then model 2 included everything from model 1, but we added vital signs. So we added SpO2 and systolic blood pressure. Now, before we get into results, I want to mention a few limitations. So first of all, the way we determined rearrest, it was a very operational definition. So basically, for every patient that had a documented ROSC time, right, which was an inclusion criteria for this study, we said, if you, after that ROSC time, received a milligram of epinephrine, had a CPR initiation, or a defibrillation delivered, right, those patients, we assume that they experienced a rearrest event, right? And of course, that opens us up to possible misclassification of some patients. Maybe the patients that got a milligram of epinephrine slammed when they had really severe hypotension, even though that's, probably not recommended in clinical practice. There could be some misclassification. As well, just because this is kind of a retrospective study of administrative data. There was some missing data, which could lead to selection bias, as well as inaccuracy of times that were documented in the electronic health record and inaccurate kind of variables that were entered. That said, there are a few strengths of our study, right? I've mentioned some of these. So we have a large sample size, larger than any of the previously conducted studies, as well as geographic diversity, right? We're looking at hundreds of agencies across the entire United States. So basically, as a long story short, basically what we found is there was no difference between epinephrine and norepinephrine for any of the outcomes we assessed. So no difference in rearrest, shockable rearrest, no difference in mortality, regardless of which variable set we used, whether we used logistic regression, whether we used propensity score matching. In our overall primary analysis, there was no difference between epinephrine and norepinephrine. Because of our large sample size, we were also able to do a number of subgroup analyses, right? And so, for example, we looked at only patients who presented with shockable rhythms, only patients who presented with non-shockable rhythms, subgroups stratified by sex, witness status, pre-EMS CPR, etiology, et cetera. And overall, most of the subgroups were consistent with our primary analysis, right? No difference between the two vasopressor agents. However, we actually found that in the subgroup of patients who were female and the subgroup of patients who had a non-cardiac etiology, we found that epinephrine was actually associated with decreased odds of rearrest. It's unclear what the reasons for this are. It could be just kind of a spurious finding. Another thing we thought about was, maybe the patients who have this non-cardiac etiology, right, the respiratory arrest patients, the patients who have opioid overdoses, maybe they have younger, healthier hearts. We're kind of looking at different physiology than the guy who has a, coronary occlusion and irritable ventricular myocardium, and they may actually respond better to some of that beta adrenergic stimulation that's provided by epinephrine. We also looked at time to rearrest, right? We have that very defined follow-up interval and documented ROSC time based on our definition. And so there was also no difference in the time to rearrest between the two groups or the rate of development of rearrest. One thing that came up during peer review was the possibility of confounding by indication, right? So basically, in this situation, maybe paramedics were choosing to give some patients epinephrine infusions for clinical reasons, right? Maybe it was an arrest because of anaphylaxis or an arrest because of asthma, right? And they were giving epinephrine for its vasodilatory effects, bronchodilatory effects, as well as its effect on blood pressure, right? And so what we did is we looked at, on the agency level, what proportion of patients treated by that agency received either epinephrine or norepinephrine. And what we found was that for about 80% of the agencies included in this study, there was 100% epinephrine given to these post-arrest patients or 100% norepinephrine, which suggests that practice was being driven primarily by agency protocol, state protocol, or medication availability rather than provider discretion. Right? So this just suggests that confounding by indication might not be as big of a concern here as we might have thought. So in conclusion, when used as a pre-hospital post-ROSC vasopressor, it seems that the outcomes for patients who are treated with norepinephrine are about the same as the outcomes for the patients who are treated with epinephrine. Our study addressed some limitations of prior literature, including the temporality between the drug administration and rearrest. Again, some previous studies, they didn't account for the fact that some patients are going to rearrest once or multiple times before a vasopressor is administered. Now, of course, more research is needed. Prospective study is definitely needed before we have a definitive answer to this question. But at least our study suggests that in the pre-hospital setting, epinephrine might not be the poison that we thought it was. Now, of course, we're looking at exposure times to these vasopressors of like 20 to 30 minutes in this study. And so it's possible that the answer is totally different when we're looking at patients who are exposed to epi or norepi for hours or days in the ICU, right? So thank you very much for listening. I'm happy to take any questions you might have at this time.
Tanner, amazing. I have a lot of questions, and I think a few people do as well. Would you mind going back to the first study? There was a that the graphic where you had um both the weight and the sex for the eye gel, because
Sure.
there was one that I wanted to right there, right there. So if you go to the less than 50 kilo and you look at the patient sex right below it, it looks like there was a much higher. I know that on the right the failure rate was the same, but for this particular weight category, less than 50, it looks like the male had a much lower rate of unsuccessful than the female, almost double, or half, I should say, for the male. Can you explain that one, or is there an explanation there?
Yeah, so I'm unsure of what the actual underlying mechanism here might be. So again, it could be just bias that's built into the data. So maybe females who weigh less than 50 kilograms are more likely to arrest or require airway management for different reasons than men in a similar weight category. So for example, if all of the men in that category had cardiac arrest and had total airway paralysis, right, as a result of ischemia. They might have just had easier airways to manage and had less failure as a result of that. But it does seem across the board that patients that weigh less than 50 kilograms had the highest rate of failure, whether they got a 3, 4, or 5 iGel. And we mentioned this in the discussion of the paper, it probably needs some more study, it needs people to think about it. What is the underlying mechanism here? Maybe it's that
So,
we're undersizing the iGels in these patients.
so as far as the take home then is from this paper is that there was no difference between weight-based versus sex-based.
Hmm.
But if you read between the lines, in the under 50 kilo adult,
Hmm.
then and I would presume child too, but in the under 50 kilo person, there may be some issues with sizing that you may have to pay more attention to.
Absolutely. Absolutely.
Okay.
Yeah.
So,
We,
okay, very good. And then on the other paper, I'm so happy that you did what you did because um, and I have the other paper up in front of me. This was done, I believe, out of the folks in Seattle. And when this paper came out, when their paper came out earlier this year, they titled it "Pre-Hospital Administration of Norepinephrine and Epinephrine for Shock After Resuscitation from Cardiac Arrest." And they came to the conclusion that patients who received epi infusions suffered pre-hospital rearrest more frequently. And you mentioned this in your paper. I'm just trying to re-emphasize here that everything you read on the internet may not be true. And there were many people who called me after that and said, "Why aren't we removing epinephrine from our unit?" So take me into your thought process. Did this idea of this paper, the second paper that you brought up, did it come because you saw that paper and said, we need a larger sample size than 451 patients? Is that how you kind of came up with it?
yeah, absolutely. Absolutely. Reading the paper, I was impressed with the magnitude of the findings, right? The effect size that was suggested there was startling to
Hmm.
me, right? Again, that number needed to harm a 4. Um, there aren't many things that would be more harmful than that if that was a true estimate of the effect size. Um, but also, if it was true, I figured we would probably have better luck getting people to change their practice if we had geographic generalizability and a larger sample size. So I was looking to more confirm their findings. I didn't have skepticism initially, because I think the mechanism is right. You have these post-arrest patients. You don't want to give them all that beta adrenergic stimulation and increase their myocardial oxygen demand and cause rearrest. Um, So, yeah, I went into it believing their findings and wanting to confirm it in a larger data set. And we came away with a bit of a different conclusion.
And this may be like a larger kind of discussion for that we can have at some other point, but what's your sense of the amount of items that are sitting in the evidence base that people are actually looking to? I'm going to give you an example of the refill trial where they said that whole blood doesn't work until you look at the fact that their whole blood was given 55 minutes later, or the pre-hospital antibiotic trial for sepsis out of the Netherlands where they said pre-hospital antibiotics don't work. And it turns out that only 3% of the patients in that study were in shock. And their overall mortality was only 8% versus the normal 40% from septic shock, where people are actually looking at these studies. It's not applicable. It doesn't make any sense, but we're just taking them for face value. As someone who is becoming very prominent in the field of EMS research, how do you advise folks like us out there who are reading these things on Twitter, reading the actual article, and coming up with the wrong information? What's your advice?
So I think that especially for the like the things that you mentioned, table one is very, very important, right? So I think the first thing you should do whenever you read any of these studies is go look at table one and ask yourself a couple questions. So first of all, is this population similar to the population that I'm seeing and treating in the field, right? Or in a hospital setting or wherever it is, right? So
Mm.
you have to always ensure generalizability to your practice setting. And additionally, when it comes to things like follow-up interval, the timing of intervention initiation, um, those kinds of things, they're like especially follow-up interval, I see very, very few observational studies, especially pre-hospital observational studies, where that's even reported, right? So I think as a field, we need to call for better reporting standards for some of these things to help us determine whether or not findings are generalizable, right? Because if it's not documented, you're not going to be able to tell from reading the paper.
Right. Great comment. I love that. Someone asked, did any rearrest have SVT requiring? Actually, I know Paul's got to go, so let me bring in Paul. Dr. Pepe, go ahead and ask your question. Sorry, I
Oh,
missed you there.
one of the problems here is that we're not, because it's post resuscitation hypotension is the theme here. One of the problems is that we're not controlling for some of the other factors that are there, such as how people were breathing for the patients at that time, and they probably were still overzealously ventilating even at the when they're resuscitated. And secondly, so there's like a lot of things are not controlled for under these circumstances, and um, I'll tell you that this is first of all, I like what you're saying, Peter. Is my whole thing about evidence-based medicine versus experience-based medicine. So if I had a study of AEDs that were done at, they showed that the study says there was no difference there between the AED and then paramedic first, and even though there's 9 minutes difference, but when you look into it, like you're saying on the refill trial or the epinephrine trial coming out of the whatever it was called, paramedic trial of the UK,
Paramedic too,
they
yeah.
weren't
Mhm.
they weren't given till later. So if someone tells me that, and I say, well, when was the first shock given, and they go 10 minutes, then you got what I'm saying is that it's not going to show any difference. So there's so many other variables, for particularly time, that's really critical in all this. For example, did they have the epinephrine and or the norepinephrine drip set up ahead of time so it can get right on board before there's all sorts of things. Did they control for ventilation? Did they control for a bunch of other factors? But and that's what you can't get here because I don't know of any studies where they're control for it. All right, well I'll just go on to the other one, but
Yeah.
I can talk later on more detail about this. Okay.
Well, I mean, yeah, thanks, Paul. I mean, shouldn't there really be a clearinghouse for this? Shouldn't there be an entity that says, here's all the things that are coming out at you, and here are the things that we think that you ought to do? Shouldn't that be the job of our national organizations? And the reason I mention that is because yesterday, someone put on Twitter, someone had reported out regarding, do you stay on scene for kids or do you scoop and run? And then so it was a nicely done article, but all they looked at was time. They didn't look at quality of CPR. They didn't look at anything. They didn't ventilatory rate. They just said, how much time are you on scene, and did that impact your outcome? Then a follow-up commentary came from three pediatric ICU doctors who have never
Yeah.
been in the back of an ambulance, if I had to guess, and they came up with the completely wrong commentary but because of their names, though that commentary ended up in
Yeah,
in the journal, right,
right.
Paul? So yeah, I mean, which is
Well,
what I sent you
so
last night at midnight.
yeah,
I was so
I
upset.
read it. I wasn't too bothered by it, except for what you're saying. And the thing is, but even people within our own field are clueless as well, so quite frankly, okay, because they haven't even been in the streets at all or know what's going on out there. That's part of the problem. So,
Right, right,
but
but
that's
Paul, why?
another separate conversation. I got to get this other meeting going.
Right,
But thank you very
it begs
much.
the question. It begs the question: why are non-EMS physicians commenting on EMS research?
Well, I
Why
think
are they trying to dictate what we do in the field? I don't
Yeah,
understand.
I think what we should do is go into the operating room, tell the anesthesiologist what they should do, right? All
That's
right,
exactly the thing. All right,
gotta
I'll see you
go.
on the other
I'll see you
side.
later.
I'll, I'll see you on the other side. Yeah. So, Tanner, do you have any comments on that? Because I, I worry that there are people out there who are good at writing things, and they have a name in the, let's call it the AHA world, and there are people out there in EMS who listen to these people. And I'm just curious as to what your thoughts are. How do we make a difference if you're thinking kind of if you're using your visionary mind for the future of EMS, how do we fix that problem?
Yeah, so I think there is definitely it's invaluable to have experience in the field when you're writing these papers and interpreting this literature, right? Again, picking up on something as simple as CPR quality when you're extricating patients, right? We all know it's terrible, right? But that might not be something that an ICU physician is going to think about, right? Um, I'm a glass half full kind of guy, so I think moving forward, as we have more EMS trained, board certified physicians, and as we have more emergency medicine physicians, getting federal funding, getting more involved in academics and research, we will be able to build kind of the academic side of our specialty and subspecialty to the point where, we will be the invited experts for the editorial and JAMA.
Right,
But yeah,
right.
beyond that, I'm not sure. Keep
Yeah,
pushing.
and just be like a clearinghouse. So in other words, in my opinion, the NAMSP needs to be that source, and there should be a panel of experts who can kind of debate these things and say, okay, there was a paper that just came out on epi versus norepi. Um, let's take a look at what we're going to recommend for people to use. Right now, how it goes is that people read the article and it came from Seattle, so it must be true. And so now all of a sudden you're going and you're telling your medical director or your EMS chief, hey, let's make a wholesale change off of this one drug to another drug without it really being fully vetted. Now, to be fair, in the paper, they did say that this outcome requires further research. And so at least that was in there, that was said there. So all right, and then let's go back to the question that didn't get to you, which was, did any rearrest have SVT requiring a shock? I mean, you probably won't know that, but what are your
Yeah, I
thoughts
mean,
on that?
so about less than 10% of the rearrests in the study required defibrillation. And so I guess that would be cardioversion, right? In that
Yeah,
case.
yeah,
Um,
yeah.
so we did not consider cardioversion rearrest. Um, so while the data would technically be available to us, we did not collect it or report it.
Okay, excellent. Before we go, see some really smart people on this call. Anybody have any other thoughts about iGel? Any thoughts about epi versus norepi? I see Lou. You're typically a vocal guy. Joseph Zalkin. Anybody else, Kim Landry, anybody else want to make a quick comment or thought before we head over to Dr. Pepe's webinar? Was end-tidal CO2 a variable, Joseph asked.
It was not in either study.
Joseph, why do you ask?
Well, I think we preach that is a indicator of effective CPR, whatever the levels of end-tidal CO2. So we have spent a lot of time developing pit crew models and emphasizing monitoring of patients. SpO2 is a late indicator of what's happening. If there was any variation in end-tidal that could be referenced to outcome.
Yeah, so I think part of the problem here is at this point in time, we don't have waveform end tidal CO2 data. So we kind of have like the scattered, you might have 4 or 5 documented values, most of the time less than that, right? And so I think it's hard at this point, right? Again, without that waveform data to actually go in and say, okay, this was a clean waveform that we can count in our analysis, right? There's a lot of confounding from etiology, right? We know like asphyxial arrests have higher end tidal CO2s. Patients that have prolonged downtimes might be more likely to have prolonged end tidal CO2s when you initiate CPR. And so I think that the signal from CPR would be lost amidst the rest of that, the rest of the factors that influence end tidal CO2. But again, and this is something that our group is moving toward, is getting access to the waveform data associated with the monitor files that are housed by ESO. So if we did that, we could actually get like the impedance files to calculate rate, right? And other CPR metrics. So that's definitely something that would have been useful, would be valuable to answering this question, but we just didn't have the resources to do it at the time.
All right, perfect. Great
David,
answer.
since you asked,
Lou, there you go. Hey, come on in.
I just have one question. So ESO, no doubt, is one of the largest data sets of the industry, but are their users representative of everywhere? The saying, you've seen one EMS system, you've seen one EMS system. I know in our area in particular, we have some high-performing systems that are not represented in that data set. So is it really applicable to all of us when I hear this?
Yeah, and so, I mean, one facet of this is there's definitely an urban bias when it comes to ESO, right? A lot of the rural agencies do not use ESO. At least that's true in West Virginia. There's definitely an urban bias. So as far as the question of generalizability, I think that there's definitely a question: is it generalizability to all settings? It's definitely the most generalizable data we have so far.
I appreciate it.
Perfect. All right. Excellent. Great question. All right, everybody. Thank you, Tanner, again for everything. I'm going to give you a call at some point so we can kind of discuss how you can kind of start to help me on these webinars. I would love to get your input and your leadership here as well. And in the meantime, everybody, I'm going to put this up on YouTube, and I'll hopefully have it up sometime by this afternoon. I have in the chat the link to Paul's webinar, and the CME codes are there if you're looking for CME. So thanks, everybody. Tanner, thank you so much. You're amazing. Have a great Friday.
You too. Thanks, everyone.
Everyone.